Good morning, good afternoon, good evening to all our participants who might be joining from all over the globe. We're actually 2 minutes after deadline, so I'm gonna go ahead and welcome you all. I hope that this is gonna be a very beneficial and interactive webinar. I'd just like to introduce myself. My name is Janelle Beeman, and I'm a medical scientist at the Center for Respiratory Diseases within the National Institute for Communicable Diseases in South Africa. I think we've got a really fantastic agenda in store for us today. And I just want to remind you quickly of a few housekeeping rules and suggestions. Firstly, to thank the US CDC for their support. I would just like to let you guys know that there's going to be simultaneous interpretation in French, Spanish, and Portuguese. And you can set which channel you want to listen to in your meeting controls at the bottom of your screen. In terms of the presentations that will be available today, one will be in French and one will be in Spanish. And so just to remind all those English participants who don't often have to tune into interpretation to please tune in to the English channel during those. Please feel free to use the chat function to exchange any ideas related to the discussions and the presentations. But if you can, post all your questions in the Q&A button, and both of those buttons are found at the bottom of your screen. Just so that you're aware, the meeting is being recorded. And the recordings and the speaker slides will be made available after the webinar. So the webinar consists of 2 sessions. And I'm actually first going to start off with the objectives. So the webinar is really to give us an understanding of how national public health institutes can further develop their genomic sequencing for SARS-CoV-2 as part of their routine surveillance systems, and also how both at a regional and international level we can collaborate and support this development of genomic sequencing. So then, as I was saying, the webinar is going to be divided up into 2 parts. The first part will be presentations from National Public Health Institutes in Burkina Faso, Argentina, and Denmark. And they're basically going to reflect on their experience with genomic sequencing and surveillance. They're going to share some of their best practices and some of the gaps that they have identified, and also shed some light into the role that regional and international collaboration has or could have in terms of developing capacities in these fields. Following these presentations, we're then going to have a really nice panel discussion. This is going to include representatives from different international organizations that are working on laboratory systems and genomic surveillance networks, and also some National Public Health Institute representatives. So if we can start off then, our first presentation in the first session is going to be given by Prof. Abdoul Salam Ouedraogo, and I apologize if I'm pronouncing the names incorrectly. Prof. Ouedraogo is the head of Burkina Faso AMR Reference Lab within the National Public Health Institute of Burkina Faso. And just to remind you, this presentation will be in French, and so please click into the relative interpretation audio channel. Thank you, Prof. Over to you.
Merci beaucoup. C'est un honneur et un plaisir pour moi de présenter l'expérience du Burkina Faso en matière de séquençage génomique du SARS-CoV-2 et le rôle qu'a joué la coopération régionale et internationale pour le développement de ces capacités. Je m'en vais rapidement vous annoncer le plan que je vais suivre. C'est essentiellement la prévalence de la COVID au Burkina Faso actuellement. Et le défi actuel qui est essentiellement le séquençage génomique pour le suivi des variants, l'intérêt de ces séquençages et les outils que nous avons pu développer. Et c'est à travers l'Institut national de santé publique dirigé par le docteur Hervé Yen que nous avons mené ces activités qui a des perspectives. Pour parler de la situation du coronavirus au Burkina Faso, comme il est important de le rappeler, c'est une pandémie inédite qui a touché le monde avec à ce jour presque 181 millions de cas confirmés, presque 4 millions de décès, Notre pays, le Burkina Faso, peut être considéré comme parmi les pays qui ont été relativement peu touchés. J'aime bien relativement parce que nous sommes dans un pays où il y a très peu de capacités de tests. Vous connaissez, au départ, c'était les PCR avec peu de laboratoires. Donc, à ce jour, le Burkina Faso compte environ 14 000 cas confirmés avec moins de 200 morts, mais il y a beaucoup de décès qui ne sont pas très bien investigués, ce qui fait qu'il faut relativiser les chiffres dans un contexte où les capacités diagnostiques sont toujours les mêmes.
Prof, can you please share your slides? We're not seeing your slides at the moment.
Don't you see? Sorry, you have my slides?
Can you share your slides? I mean, share screen to show the slide.
Oh, sorry. It's okay?
Yes, we can see it. Thank you.
Okay, so je reviens en français, désolé. J'avais présenté rapidement la situation de la pandémie dans notre pays, que je disais qu'elle est relativement peu touchée, avec environ 168 décès comptabilisés. Ça peut être faible, mais il faut faire attention parce que le contexte est, avec beaucoup de cas, peut-être peu investigué. Nous sommes en Afrique subsaharienne le 6e pays le plus touché depuis le 9 mars 2020. Et depuis cette date, c'est l'Institut national de santé publique qui a le lead pour la réponse, la riposte à cette pandémie à travers un organe qu'on appelle le Centre des opérations de riposte aux urgences sanitaires, qui est le CORUS, qui est vraiment la cheville ouvrière pour la coordination des activités de riposte. Et pour cette riposte, sur le plan laboratoire où je suis très impliqué et qui fait l'objet de la présentation aujourd'hui, au Burkina Faso, dès le départ, on a vraiment organisé la riposte et on testait sur la base des critères cliniques, épidémiologiques et qu'on adaptait au contexte local. Et les personnes testées étaient non seulement les cas suspects, les cas contacts, qui ça a évolué, mais aussi on a les voyageurs et sur le plan expertise, des travailleurs dans le domaine des mines, pour la reprise du travail parce que c'est des endroits qui sont spécifiques pour le regroupement humain. Nous avons deux types de tests qui sont disponibles. Nous avons les tests PCR et les tests qu'on dit les tests rapides. Et au Burkina Faso, en ce qui concerne la stratégie de riposte au laboratoire, nous avons beaucoup d'outils diagnostiques. Au départ, comme dans beaucoup de pays à ressources limitées, nous sommes confrontés à des réalités de terrain en termes de laboratoire. Au départ de la pandémie, il n'y avait qu'un seul laboratoire qui était à mesure de réaliser les diagnostics. Et très vite, ce laboratoire a partagé son expérience et son expertise à beaucoup de laboratoires qui ont la capacité de réaliser la PCR. En l'occurrence, tout ce qui est laboratoire national de référence, nous en avons 9. Ce sont des laboratoires qui s'étaient spécialisés sur des pathogènes, ce qu'on appelle dans certains pays les centres nationaux de référence, les CNR. Et plus tard,
we've lost your slide. Sorry, Prof, we've lost your slides again. I'm not sure why it ended the slideshow. If you can restart it, share your screen again, please.
You don't have my screen?
No, we can just see your video, not your slides.
It is
Okay,
okay?
we can see them now. Yes, thank you.
Thank you. OK. Donc, je disais qu'au départ de la pandémie, nous avons eu des soucis de diagnostic. Vous voyez à gauche les laboratoires. C'était d'abord un laboratoire unique qui réalisait. Ensuite, la technologie s'est étendue dans plusieurs laboratoires, sous toujours le leadership du laboratoire national de référence pour les infections respiratoires aiguës sévères. Et ces laboratoires ont acquis la capacité de faire les diagnostics. Nous avons au total au Burkina environ 15 laboratoires répartis dans les pays qui sont capables de réaliser les diagnostics PCR. Ensuite, le pays a pu, grâce à l'acquisition de matériel comme les gènes experts, qui sont des point of care, accroître encore les diagnostics. Donc aujourd'hui, on pourrait se situer à environ une trentaine de laboratoires qui peuvent effectivement réaliser les diagnostics PCR. Et nous avons des laboratoires de référence de grande capacité qui peuvent, avec des extractions automatiques, réaliser de grandes séries. Et pour encore décentraliser, parce que la pandémie COVID ne devrait pas désorganiser les systèmes sanitaires, on a fait ce qu'on appelle une remise de l'activité au système de santé avec la mise en route des tests rapides, et nous utilisons des tests qui sont homologués par l'OMS et qui permettent de faire les diagnostics conscients que nous devons étendre les tests au premier contact du patient avec les systèmes de santé. Et un algorithme a été mis en place. Donc, c'est pour vous dire qu'au Burkina Faso, il y a vraiment la possibilité du diagnostic de la PCR et par PCR ou par test rapide du coronavirus. Mais le défi actuel reste la surveillance des variants. Parce qu'il est important de rappeler que cette surveillance des variants est très importante depuis qu'on s'est rendu compte que après le virus décrit à Wuhan, il y a eu des variations génétiques qui font qu'il y a de nouveaux virus. Actuellement, on parle de alpha, bêta, gamma et delta avec des sous-groupes. Il est important de suivre ces variants, les transmissions, et l'intérêt de suivre de ces variants-là, du suivi de ces variants, c'est pour mieux comprendre l'évolution du virus, surveiller les mutations pour prévoir l'évolution de l'épidémie et surtout optimiser les stratégies. Et la facilité aussi d'identifier des antigènes, parce que ces variations-là peuvent avoir des implications, non seulement sur la structure du virus, avec un impact non seulement sur les tests PCR, mais aussi sur les tests antigéniques que l'on utilise, parce que ces tests-là sont designés sur la base du génome viral qui est en variation. Il reste aussi important de voir est-ce que certains variants ne sont pas impliqués à des présentations cliniques de la maladie. Donc, c'est un défi, non seulement pour le monde scientifique, pour les pays développés, mais aussi pour les pays à ressources limitées, parce qu'on voit que la pandémie corona a touché différemment les différents pays. Qu'est-ce qui s'est passé au Burkina Faso? Au Burkina Faso, à travers l'Institut national de santé publique, on a très rapidement fait un point de situation pour voir nos capacités de séquençage. Parce que séquençage ne veut pas dire séquençage. On sait que pour le séquençage des variants COVID, il faut faire tout le génome entier. Est-ce que les méthodes que l'on avait déjà dans les pays, en l'occurrence les séquenceurs de type Sanger, permettaient de faire le diagnostic? Parce qu'il convient de rappeler qu'à travers le VIH, on avait des séquenceurs, mais de type Sanger, qui permettaient de faire le séquençage au centre Muraz, qui est un grand centre de recherche à Bobo-Dioulasso, mais aussi dans un centre à Ouagadougou qu'on appelle le CERBA. Ouagadougou étant la capitale. Donc, ce n'était pas ces séquenceurs-là qu'il fallait utiliser. Donc, il fallait rapidement profiter des opportunités pour s'équiper en nouveaux séquenceurs, former les ressources humaines compétentes et prendre une décision. Et donc, le champ de coopération nous a permis de faciliter cette activité. D'abord, comme je vous le disais, d'abord par l'acquisition de matériel, parce qu'on avait déjà les séquenceurs classiques et on a maintenant les séquenceurs de nouvelle génération et NGS. Et ça, c'est un peu un overview. Je pense que comme notre auditoire n'est pas directement scientifique, donc seulement scientifique, on va se passer de cet aspect technique du séquençage et expliquer sur le plan santé publique comment est-ce qu'on y est arrivé. Donc, à travers les missions de l'Institut national de santé publique qui sont d'assurer la veille sanitaire, assurer la recherche opérationnelle et développer et animer l'expertise collective en santé publique, nous avons saisi l'opportunité. La première opportunité de collaboration, elle est internationale. Et à travers ces images, vous voyez, nous avions déjà dans l'Institut national de santé publique un projet dont l'acronyme est ANDEMIA, African Network for Improved Diagnostic, Epidemiology and Management of Common Infectious Agents, qui est un consortium dans lequel nous faisons le suivi de 3 infections principales, les infections respiratoires aiguës sévères, les infections gastro-intestinales et les fièvres d'origine inconnue. Donc, ce projet-là qui existait depuis 3 ans fait qu'on surveille dans le pays à travers 2 centres de référence, un centre qui est dans notre hôpital à Bobo-Dioulasso, le centre hospitalier universitaire Sourou-Sanou, et dans un autre district qui est situé à 200 km environ de Bobo-Dioulasso. Et toute la biologie est réalisée, une partie au centre hospitalier universitaire Sourou-Sanou, mais une grande partie pour les techniques sophistiquées au Centre Muraz, qui est le plus grand centre de recherche du pays, qui fait partie bien sûr de l'INSP. Donc, à travers ce projet, nous avons acquis un séquenceur de dernière génération avec pour objectif de voir les variants circulants, non seulement dans le projet, mais au niveau national. Donc, en novembre 2020 déjà, avant que l'on ait décrive les variants alpha, delta et gamma qui circulaient, on a fait un séquençage d'environ 100 souches au Burkina Faso. Quels sont les résultats qu'a montré ces séquençages? Si le tableau que vous voyez, la figure à droite, qui est un tableau de la sous-région, nous avons montré que cette centaine de souches séquencées appartenaient à la majorité des variants qui circulaient en Afrique de l'Ouest. Mais ce n'étaient pas des variants connus comme épidémiogènes. C'est la 19A, 19B et 20A. Donc, ces variants-là, nous disaient déjà de 20B plus tôt. Donc, les trois principaux variants qu'on a trouvés, 19B, 19A et 20B, qui sont des variants qui circulaient déjà en Afrique de l'Ouest. Mais il était important de continuer l'activité parce qu'on a vu qu'il y avait une évolution des variants qui pouvaient avoir un impact. Plus tard, on s'est encore appuyé sur une autre collaboration à côté de ce que l'on a fait avec le Centre Muraz, maintenant au Centre hospitalier universitaire Sourou Sanou, à travers un projet de recherche aussi que l'on a avec le Medical Research Council of Gambia, qui consistait à faire un suivi de la dynamique de la pandémie en Afrique de l'Ouest, acquis un autre séquenceur et avec une formation sur site, c'est la photo que vous voyez à droite. Donc, une équipe de Gambie est venue former notre équipe sur place et nous avons maintenant la capacité. Mais ça a eu lieu en mars 2020 où on avait déjà décrit de nouveaux variants comme le variant anglais, le variant sud-africain. Quels sont les résultats qu'a montré ce travail? Voici la figure qui montre sur un ensemble de souches, environ 200 souches qu'on a séquencées en mars. On a décrit très rapidement l'existence du variant anglais que vous voyez ici, le B117, les linéages, et qui circulait déjà dans les pays. De façon très intéressante, ce que ces résultats ont montré aussi, c'est qu'avec peu d'échantillons séquencés, environ 300 au Burkina, entre novembre et mars, nous avons une grande diversité des variants de COVID.
I can ask you to please wrap up. We're just running a bit short on time, so if you can just
I will finish.
summarize quickly. Thank you.
OK. Donc, ces résultats montrent effectivement que la coopération internationale a joué un rôle. Sous le lead de l'Institut national de santé publique, on a acquis non seulement 2 appareils disponibles et qui sont fonctionnels, on a formé du personnel qualifié et actuellement, le travail s'est fait. Au vu de ces résultats, pour conclure, il s'agirait à travers l'INSP de renforcer les plateaux techniques, renforcer le personnel en quantité et en qualité pour continuer le séquençage et disposer des systèmes de surveillance d'évolution génomique du coronavirus. Voici, en finissant, je vous remercie, un panel d'appareils que la coopération internationale, à travers les réseaux, on pourrait se doter pour suivre ces variants. Thank you very much for your kind attention.
Thank you, Prof, for that insightful presentation on the behalf of Burkina Faso. I'm now going to just quickly move on to our next presenter, who is Dr. Claudia Perandones, who is the Director of the Executive Unit for Higher Education and Training at the National Administration of Laboratories and Institutes of Health in Argentina. And she's just going to share her presentation with us in Spanish. So I'll just remind everyone to join the appropriate translational channel. Over to you, Dr. Perandones.
Hola, buenos días a todos. Muchísimas gracias por esta fantástica oportunidad. Quisiera saber si están visualizando mi pantalla, si están pudiendo ver mis slides.
Yes, we can see your slides, but it's not in presenter view at the moment.
¿Ahora?
Yes. Yes,
bueno, muchísimas gracias, doctor Biman. Muchísimas gracias también al profesor Abdoul Salam, porque su charla servirá de introducción para mi pequeña presentación. Me voy a focalizar en cómo se ha implementado la vigilancia genómica en nuestro país, pero desde el punto de vista epidemiológico me parece importante comentarles que estamos en nuestro país viviendo una segunda ola, y al día de la fecha hay aproximadamente identificados 4.500.000 casos y hay 94.000 fallecidos. Este es el contexto actual, y en esa situación y en ese contexto es que me parece muy importante remarcar cuáles son los objetivos de llevar adelante en nuestro país la vigilancia genómica. En el primer caso es importante establecer el nivel de dispersión de la pandemia en nuestro país, el nivel de dispersión viral, establecer estrategias de vigilancia, pero también monitorear la evolución del virus en nuestro país. Detectar mutaciones en distintos clústeres y determinar la introducción de las distintas variantes mundiales, identificar la aparición de nuevas cepas y, por supuesto, determinar si la aparición de estas nuevas variantes y la introducción en nuestro país condiciona fenómenos de resistencia frente a las vacunas y a las drogas antivirales disponibles. ¿Cuáles son las estrategias que se han implementado para el desarrollo de la vigilancia genómica activa en nuestro país? Básicamente existen dos estrategias. La primera de ellas se denomina Proyecto País, y es un proyecto que depende del Ministerio de Ciencia y Tecnología de la Nación. Este consorcio en este momento está dedicado a la vigilancia de la circulación comunitaria de cepas de SARS-CoV-2 en las 24 jurisdicciones de nuestro país. Y estas 24 jurisdicciones se monitorean para que la evaluación sea representativa en términos de sexo, edad y unidades territoriales, severidad clínica de los casos secuenciados. Y en segundo lugar hay una plataforma que depende de el Ministerio de Salud de la Nación y que está en mi institución, la INSP, y que es la plataforma de genómica y bioinformática, que se encarga del monitoreo del ingreso de variantes a nuestro país a través de los escasos puntos de entrada habilitados. Se encarga del monitoreo de las sospechas de reinfecciones y la evaluación y la secuenciación de los casos que presentan infecciones postvacunales. En el caso del Proyecto País, como vimos, es un proyecto que tiene una gran capacidad territorial. Hay un nodo central, pero después hay nodos de colección y procesamiento de muestras y que contribuyen a la recolección de datos epidemiológicos. Son 49 estos nodos. Hay nodos para secuenciación genómica, que son aproximadamente 10. Hay nodos para el procesamiento bioinformático, que son 11. Hay grupos para el análisis de la evolución viral y molecular del virus, que son 9. Y después cuentan con el soporte de los grupos epidemiológicos y de médicos para la asociación de datos a los resultados de las muestras procesadas. Esta foto simplemente la incluyo para agradecer a todos aquellos que están contribuyendo en todo el país para el desarrollo de esta vigilancia. Y estos son todos los laboratorios involucrados en el procesamiento y recolección de muestras. Esta es la ubicación de los nodos en las distintas regiones del país. El trabajo de este consorcio ha permitido identificar y comparar los linajes existentes en nuestro país con los representativos de otros países de la región, y es esto lo que muestra este slide. ¿Cuáles son los resultados a la fecha obtenidos por este consorcio? Bueno, se han realizado la secuenciación completa de 1.235 muestras, se ha logrado el trabajo conjunto de 100 investigadores y profesionales de la salud, hay 10 proyectos de investigación en curso, y para este desarrollo están participando activamente 30 instituciones públicas y privadas del país. Ahora paso a contarles los resultados y el trabajo realizado por la plataforma de genómica y bioinformática de ANLIS, que es la segunda instancia de vigilancia genómica. El primer logro se dio el 6 de abril, cuando se secuenció por primera vez en nuestro país el genoma de SARS-CoV-2 en 3 muestras de viajeros que provenían de Estados Unidos, de Europa y de Asia. Luego, la evaluación de la secuenciación genómica estuvo destinada a la identificación de las distintas cepas circulantes en distintos barrios vulnerables de la ciudad de Buenos Aires, y es esto lo que muestra esta imagen. Y en este caso esta vigilancia tuvo el tremendo valor de poder encontrar pequeñas signatures o marcas que podían identificar claramente el origen diferencial de los casos de cada uno de estos barrios vulnerables y determinar si existía un claro cumplimiento o no de las medidas de aislamiento social preventivo obligatorio que estaban en ese momento implementadas en nuestro país. ¿Cuáles son los resultados obtenidos a la semana epidemiológica 23, que es al 7 de junio? Bueno, esta es una línea de tiempo que muestra la introducción de las diferentes variantes de preocupación y de las variantes de interés en nuestro país. Como ven, ya tenemos las 4 variantes de preocupación, alfa, beta, gamma y delta en nuestro país. Han ingresado en casos puntuales, y también tenemos la distribución de diferentes variantes de interés. Esta gráfica muestra el total de las muestras secuenciadas, que al 7 de junio eran 1.261, y la distribución por edad de las mismas, y en la columna de color celeste lo que ustedes visualizan es la distribución y el porcentaje de las mismas que correspondieron a variantes de preocupación y aquellas que correspondieron a variantes de interés en color naranja. Ahora bien, la vigilancia en viajeros internacionales. Este es un punto crítico en este momento en el que hay un gran temor por la introducción de nuevas variantes. Del estudio a la semana 23 de 237 muestras, el 34% mostraron corresponder a lo que nosotros conocíamos como variante de Manaos P1 y que ahora se conoce como variante gamma. Y el 23% corresponde a lo que se conoce ahora como variante alfa y que inicialmente reconocíamos como variante del Reino Unido. El 28% restante corresponde a otras variantes que no constituyen ni variantes de preocupación ni variantes de interés. Pero es importante remarcar este 6% que ustedes ven acá en verde y que corresponde a lo que se conocía como variante andina o C37 y que ahora ha sido reconocida por la OMS como la variante de interés lambda. Bien, lo que vimos antes correspondía a viajeros internacionales, y acá vemos la distribución de muestras en individuos que no tienen historia ni antecedente de viaje, y vemos nuevamente que la predominancia está en la variante gamma, que representa el 41%, seguida por la variante alfa en un 11%. Esta es la distribución del total de muestras correspondientes a viajeros, a no viajeros, en semana epidemiológica 23. En este slide, la distribución del hallazgo de variantes está dividida de acuerdo a la situación de severidad clínica del cuadro del paciente. Y si bien el N es pequeño, me importa remarcar que nuevamente la variante gamma es la que representa los cuadros de mayor gravedad, también los de no gravedad, pero fundamentalmente en el impacto en la mortalidad y en la gravedad de los casos clínicos, la variante gamma es la que presenta el liderazgo. Y en este caso lo que se muestra es la secuenciación de 408 casos de infección postvacunal y nuevamente la distribución de las variantes encontradas en individuos inmunizados y no inmunizados, y nuevamente el mayor número corresponde a la variante gamma. ¿Cuáles son las conclusiones a las que podemos arribar? Bueno, haber podido desarrollar 2 estrategias simultáneas de vigilancia genómica ha sido muy importante y ha permitido garantizar el establecimiento de una vigilancia activa, aunque no en tiempo real, eso aún para nosotros no es posible. El desarrollo de la secuenciación genómica ha sido posible por la adquisición de equipamiento y por el entrenamiento de recursos humanos, y la información obtenida de la vigilancia genómica activa ha sido importante para la toma de decisiones críticas en salud pública. Ahora bien, ¿cuáles son aquellas debilidades o aquellas situaciones a fortalecer? Al existir dos plataformas, es importante mantener una uniformidad y un criterio importante consensuado para la comunicación de resultados. Eso es fundamental, y más aún en un contexto de pandemia. La existencia de dos plataformas ha determinado que en algunos casos haya una excesiva representación en los análisis de algunas zonas geográficas en particular, en detrimento de otras, y se ha identificado también una gran necesidad de armonización de técnicas para la secuenciación genómica. Me voy a detener un minuto en este punto, porque este es un problema que no solamente afecta a nuestro país, no solamente afecta a la región, sino que es un punto de discusión global. Ustedes saben que la vigilancia genómica puede hacerse a través de secuenciación del genoma completo viral, pero también hay estrategias que plantean la secuenciación parcial solamente de la espícula, y también se han planteado recientemente para aquellos países que no tienen accesibilidad por dificultades de equipamiento y dificultades de costo, la identificación a través de técnicas de PCR que permiten la identificación de algunas de las mutaciones que están presentes en las variantes. Si bien estas parecen ser estrategias que sirven y que apoyan para aquellos países que no tienen la posibilidad de la implementación de una vigilancia genómica en alta escala, no puedo dejar de mencionarles una experiencia que nos refirió el investigador peruano Pablo Sukayama en una reunión técnica que tuvimos la semana pasada, y en la cual ellos tuvieron un incremento importante de casos y decidieron utilizar un protocolo de la Universidad de Yale para la identificación de mutaciones puntuales en lugar de secuenciar completamente el genoma de las muestras.
Dr. Perandones, if I can ask you to please wrap up. Thank you.
Okay, I will wrap up in 2 minutes. Los hallazgos a través del protocolo de la identificación de mutaciones aisladas hicieron que ellos inicialmente identificaran el brote como producido por la variante gamma, P1, cuando en realidad después se pudo identificar que se trataba de una nueva variante, la variante C37, variante andina, o variante lambda. Entonces creo que este es un mensaje para llevar a casa relevante. Si bien hay estrategias que permiten reducir el costo, es importante en el contexto de alguna población en la cual es posible la emergencia de nuevas variantes, utilizar estas alternativas puede llevar a errores de identificación que pueden tener una implicancia grave en la salud pública. Preguntas o tópicos para analizar o para discutir en nuestra reunión de hoy. La discrepancia en los tiempos para la carga de las secuencias es muy variante entre los distintos países y oscila entre un día para algunos y un año para otros. Los niveles de secuenciación con respecto al número de casos en Sudamérica, entre el 0.1% y el 0.4% de los casos se secuencian. En Europa están alrededor del 2%, en Oceanía el 37% de los casos. Estas diferencias, estas discrepancias determinan la necesidad de fortalecer las capacidades de secuenciación genómica de las regiones, pero de cada uno de los países en particular, para que puedan, luego de fortalecer sus capacidades, compartir experiencias técnicas, resultados y arribar a conclusiones similares para tomar decisiones con respecto a la efectividad y la disponibilidad vacunal. Y por supuesto esta discrepancia también se ve en los rates de secuenciación de cada una de las poblaciones, con poblaciones donde realmente las capacidades de secuenciación por población son extremadamente bajas. Entonces los resultados pueden tener un bias muy importante, porque ¿qué grupos elegimos para secuenciar? Los más graves, solo los viajeros, los vacunados, los reinfectados, cualquier criterio sea para seleccionar puede inducir un bias en los resultados, y eso debe ser tenido en cuenta a la hora de decidir qué secuenciar. Y ya para terminar, La secuenciación genómica es una herramienta fundamental para el seguimiento de la pandemia, de la mano de la estrategia del diagnóstico. En particular en nuestra región es crítica la información porque saber cuáles son aquellas variantes que están circulando nos permite tomar mejores decisiones con respecto a la compra de vacunas, la distribución regional de vacunas, para la promoción de la producción nacional de vacunas o el desarrollo de diferentes estrategias terapéuticas que requieren la identificación de cada una de las variantes para su desarrollo. Muchas gracias.
Thank you, Dr. Perandones, for that wonderful presentation. In the interest of time, I'm just going to move on to our next presenter, who is Dr. Tyra Grove Kraus. She's the Executive President and Interim Specialist in Public Health Medicine at the Infectious Disease Preparedness Statens Serum Institute in Denmark. Over to you, Dr. Grove.
Thank you. Yes, I come from Statens Serum Institute in Denmark, which is a national public health institute in charge of surveillance and of infectious diseases and outbreak control. Yeah, I just have to change. So in Denmark, we have a population of 5,800,000 people, and we have had 2 waves throughout the pandemic so far. And this slide shows the test-adjusted case rates over time, and the spots are the number of hospitalized patients. And we have had different strategies in place during the pandemic. First, we had a containment strategy, but we ran out of test equipment, so we had to move to a mitigation strategy, and we did that at the same time as we made a major lockdown. And when we reopened, we went into a suppression strategy where we tried to suppress the epidemic while keeping the society as open as possible. We also scaled up the PCR test capacity in this period, but even so, we were not able to avoid a second wave in this autumn. We had a long lockdown until the start of February, where we all, because we saw the Alpha variant take over, and we wanted the case numbers down as far as possible until we opened, because of the increased transmissibility. And we started the gradual reopening in the beginning of February. And as you can see, we have avoided to get a third wave. And we think that one of the reasons for this is that we have had a very high test capacity, both for PCR tests, but also for antigen tests in the spring. And then we have done a lot of whole genomic sequencing, and that has helped us to stop chains of transmission and to support contact tracing and also outbreak investigation. Furthermore, we have a real-time digital surveillance system, which has supported the early detection and response of surges in cases. This slide shows the number of tests taken during the pandemic, and the light blue are the PCR tests, and the dark blue are the antigen tests. And you can see that 1.5 months ago, we had the highest number of tests taken in 1 week, more than 4 million tests. That's almost, what is it, 3/3 of the population that were tested within 1 week. So it's a very high test capacity. And of course, what has also helped us to control the epidemic has been the rollout of the vaccination program. Right now, we aim to sequence all PCR positive samples, and those who are test positive in an antigen test, they are also recommended to have a PCR test taken so that we can do whole genomic sequencing. This slide shows the number of confirmed cases with the gray bars and the number of cases where we have been able to obtain a genome by sequencing. And you can see that during the spring, we have almost been able to sequence all positive samples. And in total, we have sequenced about 150,000 samples so far. We have a centralized model for sequencing. So we have you can get tested in the healthcare track with a PCR test. Those tests goes to the local clinical microbiology lab, and they can share with us either the sample if they don't do sequencing themselves, or they can share the whole genomic sequencing data on a shared data platform. Then we have the community track where people can get tested with PCR or an antigen test, and they can share and the sample goes to our institute, and from there we can do a targeted PCR for different variants, but we also do whole genomic sequencing and bioinformatics, and then we can analyze the data and provide regular updates. So we have been able to study the different lineages over time in a quite detailed manner. Here you see the 10 most common lineages within the last 6 months in Denmark, and we could see we actually could predict quite early on how the alpha variant would develop, and this is the red one on the slide, and you can see that we have actually had a very low proportion of other variants the most recent months, and that's changing now with the Delta variant. And you can see this is the most recent development of the Delta variant in Denmark. It was introduced in week 13. We had the first case, and then we mainly had travel-related cases and we actually were able to contain the spread by doing intensified contact tracing around the cases. But you can see within the last week, we have had a sudden surge in cases from 66 in week 23 to 87 in week 24, and now we have more than 183 for week 25, and they now comprise almost 1/4 of all cases, and we actually expect it to be the dominant virus next week. The strength in our surveillance system is that we have the possibility to link data from different data sources. So we have a national microbiology database with all the COVID-19 PCR test results, also the antigen test results. And then we have a personal identifier, so we can also link with the data from whole genomic sequencing. We can see whether people have been hospitalized, whether they have received intensive care by linking to the National Patient Register. We can also see whether they have underlying illnesses. We can have a civil registration system where we can look into their ethnicity, where they live. We can look into who they live together with, and in that way we can also study attack rates within households, and of course we can also look into mortality. We have a vaccination register, and that allows us to look at vaccine failures and also to estimate vaccine effectiveness, also variant-specific vaccine effectiveness, also by product. And we also have other registers. We have a register for all residents at nursing homes. We have registers on school pupils, and also a register on where people work, which allows us to study outbreaks. So altogether, when we link the sequencing data with these data sources, we can assess the severity, the transmissibility, and also the immune escape of new SARS-CoV-2 variants. And of course, it's a lot of work to do this, and we do not have all the resources always to manage all the data we have access to, but the data is there. One of the challenges during the pandemic is that we actually need collaboration between a lot of different people in order to assess the risk associated with these variants. So now we have set down a special risk assessment expert group where we are represented, and that's because we are in charge of the risk assessment. And then we have forces from both epidemiology, virology, bioinformatics, and also mathematical modeling. And then we try to connect with those who are in charge of the risk management. So we need to assess the risk, but we also need to link the risk to a response. And in this group, we have representatives from the Danish Health Authority who are responsible for the test strategy, and they also provide guidelines, and also they're also for healthcare workers, and they're also responsible for the communication to the population. And then we have the National Patient Safety Authority represented, who's in charge of the contact tracing. So in this group, we try to assess, based on these different variants of interest, variants of concern, and the development, is there any need for special precautions regarding travelers who should be tested or in quarantine? What about contact tracing? Because we actually do intensified contact tracing around variants of concern, where we not only trace the close contacts, but also the contacts. And we also do provide them with additional isolation checkup calls. Sometimes we have found out that there was a need to develop a targeted PCR test in order to get a more timely result. So now we have a targeted PCR test for most of the variants of concern. But it could also be that we could see an increase in a certain area and would advise that you increase the testing rate in this area or in a certain setting. And finally, in this group, we can also see whether there's a need for more research or more analysis to be done. So we've used whole genomic sequencing for public health action. We've used it to study transmission chains. We had this situation in Denmark with a huge outbreak in mink because we have had a lot of mink farmers in Denmark, a high density of mink farming. And we could study how the virus was transmitted from humans to mink and back to humans and out in the society. We could assess the public health risk associated with mink farming, and we could also assess this very high occupational risk of working with mink. We can detect and also learn from outbreaks. Recently, we saw an outbreak with this lineage B11519 that was first detected in Mexico. And that was actually linked to a traveler, and we could see how this outbreak spread. So at the restaurant, there were 25 workers that were infected, and also I think 10 of those who went to the the visitors at the restaurant, but we ended up with more than 200 cases because there was transmission to households, to schools, to workplaces, and that's been very interesting to learn from an outbreak like that. Then we do this intensified contact.
If you can please wrap up.
Yes, I have just one slide left. And we have also used it to do modeling, so projections of the alpha, how the alpha variant and the delta variant would develop, and also to assist us with travel recommendations. So for international whole genomic sequencing collaboration, it would be nice if we could increase the global capacity, if we could share data more timely. Maybe if we had a platform for sharing information on imported cases, because that would give us an overview maybe of what variants are circulating in those countries that don't sequence so much as others. Then there's really a need for very good public health microbiology bioinformaticians. That's what we have learned with our experience. And then whole genomic sequencing data cannot stand alone. We need to link it with clinical and demographic data if we really want to assess risks associated with new variants. And finally, when COVID-19 is over, maybe if we could also combine data from the veterinary side and maybe food safety whole genome or food product whole genomic sequencing data, that would also strengthen our ability to detect outbreaks and to respond to outbreaks. Thank you so much.
Thank you, Dr. Grove, for that presentation. That was really wonderful. So we'll take some questions. I see there are some questions in the chat, but we'll take them during our panel discussion session, which I think we should just move along to, considering we ran over time a little bit. So please, if you have any further questions, please put them into the Q&A box. And if there's time, we will allow you to ask your questions directly. Otherwise, the panelists will and the speakers will respond to them in the Q&A box. So for the next part of our webinar, we have 4 panelists who will really answer the pressing questions and open up this discussion. So we have Dr. Massab Umair, who is a senior scientific officer at the National Institute of Health in Pakistan. We have Dr. Lisa Indar, who is the Director of Surveillance, Disease Prevention and Control Division at the Caribbean Public Health Agency. We have Dr. Yenew Kebede Tebeje, who is the head of the Division of Laboratory Systems at the Africa Centers for Disease Control and Prevention. And we have Dr. Juliana Leite, who is a laboratory specialist at the Pan American Health Organization. So we do have some questions that have been selected as priority, and I think we'll go through those questions first, and then depending if we have time, we can open up questions to the audience. So to our panelists, thank you for taking the time to join us today. The first question is, what are the current main gaps and needs in countries' genomic sequencing capacities that you identify? So what technological data management capacities are lacking, what human resources and competencies are needed? And I'm going to direct this question to Dr. Umair and Dr. Indar. Dr. Umair, maybe you can start the discussion off, and Dr. Indar, you can add subsequently. Sorry, Indar.
Thank you so much, Dr. Jinal, for the introduction. I'm really grateful to International Association of National Public Health Institutes for the invitation. Can you hear me? Okay.
Yes, we can hear you.
So before I go to the question, I will briefly explain the scenario of COVID-19 testing in Pakistan. So in Pakistan is basically a country with a population of around 210 million people. And as of today, we have around more than 950,000 cases of COVID-19 and more than 22,000 deaths. So the initial of COVID-19 in Pakistan started back in February 2020, and NIH was one of the first institute to start the testing of COVID-19. Initially, we just had 4 labs in the country, and but gradually the number has increased, and as of today, there are 202 labs that are doing PCR-based testing across the country. So the first case of COVID-19 in Pakistan was detected on 26th of February last year. And if I talk about the genomic surveillance, Pakistan is basically at the initial stages of genomic surveillance. There are just 4 labs or institutes that are doing genomic surveillance. And that too has basically increased in the recent past. So we have done sequencing of more than 500 cases, which still is on the lower side, but we are increasing the throughput. And coming to what NIH has done, basically NIH again started the genomic sequencing last year in March. And we identified the first G614 variant in Pakistan. We also identified the first case of the alpha variant. And in fact, our lab diagnostic using the spike gene target failure and whole genome sequencing, we very timely reported the increase in cases of alpha variant in the country. And I think it led to very timely response activities from our National Command and Operations Center. So at the moment, we have just, the third wave has almost subsided in Pakistan, which was mainly caused by the alpha variant. And apart from that, we have also detected the beta and as well as the delta variant from our country. And to share with you all, we have seen a recent increase in cases due to the delta variant. And these are done basically on whole genome sequencing. We are also using genotyping based PCR based kits to identify this SNPs. So it's a combination of both genome sequencing as well as these kits. So coming to your question, which was about the basically the gaps. So at Pakistan, as I mentioned earlier, there are just 4 facilities that are currently doing the genomic surveillance, and the throughput is obviously quite low. So there's a need to increase the genomic surveillance across other regions of the country. And if I talk, there are certain gaps in technical expertise, especially when I talk about the bioinformatics, the analysis of NGS data, and then interpretation. Then there is another challenge of availability of the reagents. I think it's a global issue. Maybe the reagents they take a lot of time to reach to the country. And one of the, I think, major issues that Pakistan is facing is the lack of funding. We all know genomic surveillance, it's an expensive technique, as expensive, requires expensive as compared to the PCR especially. So at the moment, there is little funding available for genomic surveillance, but with the support of the government, we expect to see an increase in funding from government and other relevant stakeholders. What we are doing at NIH basically is we are providing genomic surveillance to different labs across the country. We receive samples from different geographic areas, from different labs, and we do both PCR-based testing and genomic sequencing, and we share the results with these labs, as well as with health authorities and the National Command and Operations Center for timely response activities. Secondly, we are sharing our own experience and protocols with labs that are doing sequencing or are doing PCR-based testing. So we constantly share our experiences, what we learned from our lab work with all the labs. And most importantly, recently National Institute of Health has, with the support of the Ministry of Health, we have developed a National Genomic Consortium. And I think which was a very, very important step that was taken by NIH and by the government. At the moment, there are 8 different institutes involved in the Genomic Consortium. But this is again an initial phase, and we hope to increase these institutes. They include both the public and the private sector institutes, as well as universities. So there is, we are basically going towards an increase in throughput of genomic surveillance. And hopefully with the formation of the National Genomic Consortium, we expect to get much more sequences in the future. Thank you.
Thank you, Dr. Umair. Dr. Indar, would you like to add your experiences as well?
Yes, good afternoon and good morning to all our different viewers. So we at the Caribbean Public Health Agency, we are the only regional laboratory for the Caribbean. We serve 26 countries. And so like the previous speaker, we do get samples. So when it comes to testing for COVID-19, we recommend the gold standard, the PCR testing, and then samples are then sent to us for further differentiation. In the beginning, we have a network right now with a university where CARPHA and the university works to do gene sequencing. countries, there are a couple of countries, we have some big countries that have now also started their own gene sequencing, not necessarily whole genome, but gene sequencing. So those are like Jamaica and Barbados and some private labs in Trinidad and Aruba and so on. I say that to give the context and to just talk about some of our challenges. Gene sequencing is so crucial for us because we have seen a change in our epidemiology due to different variants. So the Caribbean, I want to say our rates of infections have been pretty low, but in the last couple of months, the numbers have been increasing, and has been due directly to, having identification of these variants that are more transmissible and more virulent. So through gene sequencing, we have identified all 4 variants in the Caribbean, all 4 variants of concern, and we have identified some variants of interest as well. What we have seen in our epidemiology as well as in the countries where they identify, we see that increase in infection. So our push right now is to work with our countries to build their capacity and to work with international agencies and our universities to create networks. So we are working, we have started discussion with the Public Health Agency of England to work with them, as well as PAHO, Pan American Health Organization, where we can create a network, when we can build capacity to keep doing this. And that leads me into your question, what are the challenges? That is the challenge. The challenge is human resources and costing to do it. It's not an easy initiative. It costs a lot of money, and it's not just all about the money. You need people who are well trained, not just to do the methodology, but to read, the whole bionumerics and so on. So that is our biggest issue. CARPHA is really committed to kind of work through these challenges, making sure that, even if we do get data, that they are verified, that persons are well trained and so on. But for the Caribbean is the costing of these reagents, as well as the right human resources to do it.
Thank you. I think those challenges are probably things we can all relate to, definitely. Yes. Thank you, Dr. Umair and Dr. Indar. Appreciate your feedback on that question. I then just want to move on to our next question, which I'm going to pose to Dr. Leite and Dr. Kebede. And this is, how can international and regional networks and corporations participate in reducing regional disparities? I mean, I think we've all seen it from the presentations, the huge, difference between the ability to sequence genomes in various countries. And specifically to our 2 panelists for this question, what is your experience in regarding and addressing these regional disparities? Dr. Leite, if you want to start us off on this discussion.
Hi, good morning, good afternoon, everyone. Thank you very much for this invitation. Indeed, a very good webinar, very enriching, and I want to congratulate the colleagues, Dr. Salomon, Dr. Perandones, and Dr. Kraus for their presentation. That was really good. What we can share, as Dr. Indar was sharing, I think something that is really important is not to create new networks, but to strengthen the networks that already exist, so we don't duplicate efforts. So this is something that we have been working here inside the region. So for the Caribbean region, for example, we have CARPHA, we have, and indeed for the Americas, we have the COVID-19 Genomic Surveillance Network from PAHO. And this goes like an umbrella over the other networks existing inside the countries. So I think this is something that is key when we talk about networking. And as facilitator, our goal is to strengthen this network among the laboratories, because here in a region, the American region is very heterogenic. So we have countries that have strong capacity, sequencing capacity. And of course, when we talk about next generation sequencing, we need a strong bioinformatic analysis capacity and technical skills. So it goes beyond the laboratory analytical part. So this is something that we have a lot of difference here in the region. We have countries that have no sequence capacity. We have countries that can sequence, but that doesn't have the strong bioinformatic and analysis capacity. So we try to support of this country. So something that is really priority here in the region, we have been working with the, we call regional sequencing laboratories. So this provides the opportunity for these countries that don't have sequencing capacity to ship their samples so they can have the genomic surveillance of the virus that are circulating inside their countries. And that Dr. Perandones said so something that really relevant, the types and of methodology, the protocols. So we have standardized protocols that are validated on this laboratory that are shared through the network. And indeed, it is something important because it goes beyond only knowing in surveillance what is circulating in the country, but also for notification through international health regulation. In this notification, you have to notify the correct virus that was detected, the correct variant. So we have guidance and recommendation also for this. When it's the first detection by PCR, if it should be, that it should be the first detected and confirmed by sequencing, previously to recommending, to notifying to international health regulations. And of course, another thing that is important from our experience is that Dr. Umair, he shared that, for example, the challenging for the reagents, of course, they're very expensive and not always accessible, easy, available for the countries. So we have this experience as gathering all this reagent and redistributing to the countries that have this sequencing capacity. So another experience that I wanted to share, for example, a country from Central America, they generated the data, the raw data, but they requested support for analyzing and extracting the final sequences. So indeed, it was one of the laboratories that Fiocruz, one of the sequence laboratories, supported not only on this analysis, but they also provide the training to the country. So the country could have their own skill, because it's important each country to have their own capacity to do their genomic surveillance. So I think the message at the end is this, not to duplicate effort, but everyone to work together, because only through a strong networking that we're going to be able to mitigate this pandemic and generate good quality of data. Thank you.
Yes.
Thank you, Dr. Leite. Yeah, very spot on comments, I think. Dr. Kebede, can I hand over to you as well?
Yeah, thank you. Thank you, Janelle. Thank you, IANPHI, for inviting us in this very, very important panel. I'm happy to sit with these distinguished panelists and share the experience. So here at Africa CDC, you know, Africa CDC is a continental public health agency sitting within political institutions, the African Union. So the topic that we are discussing here, the disparity. I think there's huge disparity from continent to continent, and then also within countries within the African Union. So we started with the assessment of the pathogen genomics capacity in the continent, actually before even COVID started, I think before 2 years ago. And we found out that, you know, 80% of pathogen genomic sequencing capacity is in research and academic institution. It is not with National Public Health Institute or Ministry of Health. And even that capacity that's available is like, you know, very, very limited in terms of the throughput of sequencing. They were using very, you know, old equipment. The process is not automated. And again, you know, the reagent supply was not continuous. and cost per sequencing was very, very inhibitory. It was very expensive. So after this assessment, we wanted to change this status quo. So as Africa CDC, we launched the African Pathogen Genomics Initiative, which is trying to address, all the gaps that we identified. And then we created a network that has 3 layers. One is there are specialized centers across the continent. We do have regional hubs. And then there are national reference laboratories. So for those countries that cannot do sequencing in country, so we have created a continental specimen referral mechanism where we have a contract with 2 biological specimen couriers. And then we have online request submission, including metadata. So countries can refer the specimen to the next level. So coming to your question on the role of these regional and international networks and corporates in supporting this. So we have created that platform, partnership platform, so that any partner can join us in supporting this system. So we have had very good partnership with Belinda Gates Foundation. We do have also partnership with MasterCard Foundation. We have also worked with the companies to subsidize the cost. Actually, most of the equipments that are coming to Africa are through donation. So that's really a very effective partnership. Currently, we are focusing in building capacities in national reference laboratories, where we will be supporting more than 20 countries. So especially, this is a public-private partnership with manufacturing companies to liberalize the use of pathogen genomics for routine surveillance is very, very important. Today, as you see, new equipments are coming, high throughput with reduced cost per sequence. So it's important that we keep those national public health institutes with those important and latest equipments so that sequencing becomes cheaper. So these partners can contribute in that initiative. And then it's important we also emphasize, ministries and national public health institutes prioritize also and utilize the use of utilize pathogen genomics for public health decision making, translate the finding into decision making, and then with that understanding, we hope that more and more support will come also from the government side, and we can support national public health institutes. Once again, thank you for the opportunity. We have started a long journey. Hopefully, we will have a very strong pathogen genomic surveillance capacity within Africa. Thank you.
Thank you, Dr. Yenew. And yeah, I can attest to the successes of the Africa PGI. It's really been a great initiative. I then want to just move on to our next question, which I'll direct towards, I forgot to mention this, but any of our panelists who want to contribute to answering any questions, please feel free to do so. I'm just directing it to ensure that we finish on time. But the next question is, what could a network such as IANPHI do regionally and internationally to support networking of national public health institutes to improve genomic sequencing capacities and to act in complementarity of the existing laboratory networks? So I'm going to direct this question to Dr. Umair to start us off with, and Dr. Yenew, you follow on. Dr. Umair, are you still with us?
Yeah, sorry, can you hear me?
Yes, we can hear you, thanks.
My mic was on mute. Yes, so answering your question, yes, IANPHI, I think, can contribute towards the improvement and coordination between different labs. And I think it can provide a platform where different labs in the region that have developed the NGS capacities, they can share their experiences, whether it's the lab work or it's the dry work like NGS data analysis using the bioinformatics, what software they are using, what challenges they face in their sequencing, and how do they troubleshoot it. So I think ANPHI can be a great platform for sharing of experience and best practices between different labs. And I'm sure, and I can just share a small example with all of you. We did from environmental surveillance, we carried out sequencing of partial sequencing of basically SARS-CoV-2 a few months back. And we found that after the initial concentration of the sewage sample, if we just give a high centrifugation step for 3 to 4 minutes and use the pellet for processing, it really helped us in getting high viral loads. And that really helped us in sequencing. So just these type of small things, if we can share with all the labs, I think it can really help us. Secondly, I think IANPHI can, again, it can provide a platform for trainings maybe. And I know the on-site training, they might not be possible due to travel restrictions, but maybe remote trainings and especially on the bioinformatics, as pointed out by my panelists. I think this is an area where there is a lot of need for improvement and sharing of information. So maybe a training or a training course, something like that, maybe that can be shared with the regional labs. That will really help. And how to interpret the data, that is also important. We talk mostly about the lab part, and then, but we forget that the interpretation of the data is very important. And I think lastly, it is very important that there should be a regional platform where all the labs, they can very timely share the sequencing and other information. I think this was also pointed out by Dr. Tyra from Denmark, that maybe sharing of an importation of cases into the country. If we can share that with other labs or maybe what variant of concerns are prevalent in the country. I know there are public data banks like GISAD and CBI, but maybe a regional platform that can share such data will be really helpful in control of the disease. Thank you.
Thanks, Dr. Umair. Dr. Yenew, can you add your comments as well?
Thank you. Thank you, Janelle. I think that's been well said by Dr. Romi. Maybe I would like to add, IANPHI, as you know, it's an association of national public health institutes. I think there are, more than, 90 or so countries as membership. So which means that, IANPHI is in a better position and has leverage to bring public health institutes together at regional or international level. So the first thing that I see IANPHI can do is, a high-level advocacy on the importance of incorporating whole genome sequencing in disease surveillance and outbreak response. Because, this is not a common practice, especially in the African continent. And then, as a previous speaker said, IANPHI can work with the existing laboratory networks to really identify what are the gaps and then come up with immediate intervention, immediate strategies to strengthen pattern genomic sequencing. because, as I said previously, sequencing mostly is in Africa is in research and academic institutions. So IANPHI can bring this discussion to national public health institutes to have the capacity. So I agree with the previous speakers that there is a lot of requirement on human resource development, both on the laboratory science side and also bioinformatics, very, very important, especially for the African continent. And sharing of data, we found that to be also a big issue. If you have a network of national public health institutes, and then you can advocate on open sharing of data so that the data is accessible to all. And then maybe, it is an association. IANPHI can also advocate a public-private partnership to make pathogen genomics affordable and accessible to all national public health institutes. As it was said by the last speaker, IANPHI can facilitate translation of pathogen genomics data into public health decision making. I think those are the areas that I see IANPHI can contribute. Thank you.
Thank you, Dr. Yenew. I'd just like to invite any of our panelists if they want to add any contributions to this question. If not, there is a question in our Q&A box that I'd like to take, but if any of our panelists want to add, please feel free. Okay, looks like not. So the question in the Q&A box is actually directed to Dr. Grove. It says, for the cross-border risk assessment in EU and probably wider, ECDC is the institution that with that functionality or with that function, certainly in the EU. ECDC is going to have a broader mandate, and what is your experience of cooperation in that aspect? So Dr. Grove, please go ahead and you can answer.
We really appreciate the collaboration with ECDC and the way that they support us with their ongoing risk assessments. But when it comes to these SARS corona variants, I mean, it's so new for all of us, and we are all kind of struggling to follow the development. And so we really need to, we have had we meet actually every week in a network of countries with ECDC and WHO Europe to follow the situation in our countries. And ECDC has also come up with regular risk assessments around regarding the different variants, and that's very useful for us. And they're also setting up now a dashboard showing the data from the different countries. But everything, when something new occurs, it takes some time before it's in place. And I think that's just, we have to find out how we can share the data from each country, because also the studies that we do on severity and immune escape and vaccine failures, so that we have a shared data platform where we can look into these data. But we very much appreciate the collaboration with ECDC and their support to us.
Thank you, Dr. Grove. So I think if there's any other questions, please feel free to put them in the box, or even if you would like to, I see one hand up. Let me ask Hadis Mohammed, do you want to go ahead and ask your question? The organizer can allow the participant to ask the question. I'm not sure if that function is available yet. Hadis, can you ask? You've been given permission to to speak or capability to speak. So please go ahead and ask your question. Maybe there's okay, maybe the question has been answered. So I'd like to invite any of the panelists if there are any other comments you'd like to make at this point. We have a few more minutes, we have 4 more minutes. If there's anyone else who wants to comment, if not, I can go ahead. Dr. Indar, go ahead, but you still
Yes.
need.
I mean, I just want to reiterate all that have been said today. And for this to really work, I mean, we're dealing with a global issue and we're dealing with interconnectedness with travel and with everything else. So we need to have the networking. I'm really heartened to hear about how we can share information, how we can share and build capacity. So as a public health agency, we are committed to be working with the different partners to get that done.
Thank you. Any other panelists? If not, I would actually just like to respond to one point that was brought up by Dr. Umair about having a regional kind of platform for sharing, you know, the certain information about related to travel. I think it is probably important for us to have some regional capabilities and capacities developed. But I think the GISAID platform has been so extensively developed over this past year and a bit. It's really, the functionality has improved so drastically and so dramatically, especially in the last couple weeks, I think, that I think we should maybe, in line with what Dr. Leite said, not duplicate efforts and take advantage of that system that is up and running, and also you know, provide feedback where we feel that perhaps they are not covering some of the regions or some of the areas appropriately. But in my experience, it's really helped, especially, you know, even though we have bioinformatic capacity here, it's really helped with some of our analyses because it really does take the load in terms of some of the analyses. Dr. Leite, please go ahead.
No, I just wanted to reinforce what you're saying. I totally agree with you. Depending on the aim of the data sharing, because indeed in WHO, we also have epidemiological alerts, bulletins. At PAHO website, we have daily bulletins, and we have not only the genetic information, but the epidemiological information as well. And especially what you're saying about GISAID platform, because they have the metadata information when you upload the sequences. So this is all gathered in one spot. So I totally agree with what you're saying, because this even makes all the work globally easier. Because if we would have several different databases, it would be hard to go to each one, and you can even have duplicated information. So I just wanted to reinforce what you were saying. And again, to congratulate for this wonderful webinar, very important. And I think we have to be discussing so we can network and work in collaboration, because sometimes maybe we're in our region, we are in our country. So it is important to see what is the challenges we have globally, because at the end, I think it's almost the same challenges that we have worldwide among the countries. So I want to thank you very much again, and to congratulate again for this wonderful webinar.
Thank you, Dr. Leite. And then,
Yeah, can I add something?
Yes, please go ahead, Dr. Umair.
Yeah, thank you. Yes, I agree with what you and Dr. Julian said, but I think there is a need of a platform where maybe not the genomic sequencing, but maybe the genotyping data and the variant kits that are being used, that should be shared, and we can do that very I think effectively within the network, because we have used these variant kits very effectively in Pakistan, to see the trend of whether it's alpha variant or the delta variant. So maybe something not related to genomic surveillance, but things like these, if we can share with our network, that would be really helpful for us. Thank you.
That's a good point. Thank you, Dr. Umair. We are over by 1 minute, but I'm going to allow if anyone wants to add any more comments from our panel. If not, then I think we can close the webinar, and I would just really like to thank all our speakers and our panelists. I would also like to thank the participants and our interpreters as well, and the organizers. I think this was an excellent session. Lots of good points raised, and thank you especially to our speakers for sharing their experiences in their countries. And just to remind everyone that there will be a recording available and the slides as well. And they'll be sent over on email, but also be available on the IANPHI website. So thank you everyone for joining.